which are more convex than concave. Numerous ligaments, obviously in between each bone there's ligaments. It is if you just want to think of the radius as concave moving on the complex carpals, I am A-okay with that. It's more complex than that, but we'd be fine with that. Mid-carpal, so between the two rows of carpals, we've got distal surfaces of scaphoid, lunating, tricruterum articulated with the proximal surfaces of trapezium, trapezoid, capitate, hamate. Again, the convex-concave relationship for the most part. Don't worry yourself too much there. I want you to know that there's two rows, this row and that row, and then of course this articulation here. When I say a disc, I don't mean like a disc in your back disc. It is very, very small in between the radius and the carpals. This is a cross section if that helps anybody. Through the wrist, carpals here.
Is this a sagittal?
I'm sorry?
Oh, no, this is sagittal.
Sagittal view, yeah. And then the carpal metacarpal joint here. But you can see the convex concavity relationships here. And when we talk about mobilizing these, we'll show you some glides and things that can be helpful. Ligaments of the wrist. Know all of these and know how to spell them. Just kidding. Know that there's a lot of them. Now I know why hand surgeons are the way they are. Do you look at this? The ligaments through here? Hand surgeons are the most meticulous people on the planet. Ever. I've never met one that wasn't like super type A and
Very, very like structured.
super detail oriented people for obvious reasons here. All right. Obviously, flexion of the carpometacarpal joints is going to allow for gripping. Extension obviously allows for release of objects, a ball, anything that you're picking up. CMC of the thumb is different. We got that saddle shape, looks like a Pringle. We've got the, so we got, for here, what's that going to be? Abduction. Adduction, flexion, extension, just the opposite of what it should be. Collateral ligaments are taut in flexion. So if we flex the wrist and the hand, all of these collateral joints will be taut in flexion. Really think about that. Concave on convex, I can see that one. IP joints have collateral ligaments but taut in extension. Yeah, it's going to be much more stable in extension. You can mobilize these a little bit in flexion, but not in extension. Not worried too much about that. Again, look at the ligamentous structure around every joint in our hand. Extensive. That's just an appreciation. Length tension relationships, we talked a little bit about this before. Function of the hand requires a balance between the extrinsic and intrinsics. The best one I can give you is if you are fully flexed here, these are too short and these are too long. So if you have your wrist flexed and you try to make a fist, it doesn't work. You have to get into a little bit of relative extension to be able to make that good fist, okay? These are then a little bit lengthened, and these are a little bit shorter. But you're never gonna be able to do anything like that.
Oh.
Get a cramp, yeah. Same thing here, it doesn't really work very well. It's a little bit easier there because you'll end up coming back into neutral a little bit more. But think about that. Would that be active and passive insufficiency at its finest, of course?
Yes, absolutely.
The extensor mechanism, this stuff is awful, I'm so sorry.
I know, you should just keep it.
I'm gonna just say there is an extensor mechanism. You all good with that? Because I can't tell you much about it, I just don't deal with it very much.
Yeah,
Hmm.
I need to go and speak to him.
So I will tell you this. Anybody had trigger finger? Anybody seen anybody with trigger finger?
So like, where they're like, their finger is like in a permanently locked position.
It's not in a lock position, but it gets stuck. It gets stuck. So the pulley system that we have with our flexors here, okay? They all sit within this mechanism here that allows for this movement to occur and to occur smoothly. If you get an inflamed tendon, or the term is inflammation of the synovium around the tendon, tenosynovitis, do y'all remember that term? If you get this, it's always abbreviated TSV. If you get TSV in one of these flexor tendons, and it can't travel through the little pathway, it gets stuck, and that's called trigger finger, okay? You'll end up having somebody that just can't bend it, and all of a sudden it kind of locks and clicks and all this kind of thing. It's really odd looking, and then they have trouble extending it. So what they do with that is they will just shoot cortisone into that hood, and it's actually the flexor retinaculum, it's not the extensor mechanism, that would be the opposite side, but they will shoot cortisone into that flexor retinaculum to allow for that inflammation to subside and allow for that tendon to move, okay? So that's the treatment for that. If you see somebody in PT, you know, a lot of times this happens, you know, you're working on somebody's, your back or whatever, and they say, oh, I got trigger finger, I can't move this, it locks up on me. Tell them to go get an injection of their finger. You can work with them on stretching it and stuff afterward, but that's what will calm things down to allow for that movement to occur. That's something OT might deal with, but more times than not, the injection does the trick. So we know we've got lumbricals that do this, right? Remember the L, upside down L? Lumbricals are responsible for MCP flexion and extension of the PIP, all right? And then we've got lumbricals, interossei, gonna be here, keeping fingers abducted, and the, let's see, oh, I forgot. Flexion, lumbricals. I don't want to tell you wrong. One of the interossei does this, and one of them does this. Intrinsic and extrinsic.
Is it dorsal and palmar?
Dorsal and palmar, that's what I'm looking for, thank you. We've got these grips, I think we went over this as well. Cylindrical tip to tip, hook grip, chuck will be holding a pencil, spherical grasp, and a lateral pinch, like you have a key.
Do the way people hold their pens and stuff, like, is that something you would like correct? Cause like some people hold their pen and feels like all kind of way.
No, I'm not touching them. Just let them do what they do.
Okay.
Now, if they've got some kind of functional limitation,
Like where they can like grip the pen and
But
all,
again,
but nothing like, there's some proper ways to hold
I
the
can
pen.
count on one hand the number of times I'm having to work on someone's hand. I will work on a wrist all the time. Happens a good bit. But OT is so we're gonna do the hands. You can have them. You just gotta know it for boards, sorry. Nerve disorders, all kinds of ways. Most common would be compression. You know, we've talked a lot about carpal tunnel. What nerve is that? Median nerve compression. It can be external or it can be internal. You could have something mechanical or an ischemic injury. You've got something that bleeds out. It's going to compress. You're going to have some problems with that. Lacerations, see those a good bit, especially in the hand. I mean, it's easy to cut something. You can snip a tendon, a nerve, what have you. Tensile loading and stretching. I don't see that nearly as much. Radiation, electricity. Electricity is wild. I mean, I told you all about my guy who grabs the live wire, goes all the way through him to the other side, blows his fingertips off on this side, but skips his heart. Amazing, amazing. Tore up both shoulders. He had to have rotator cuff surgery on one, and it messed up his AC joint on this side, blew out his cuff here, and literally blew his fingertips off on this side. Crazy. How he's still alive, incredible. Trying to think any other nerve disorders. Most of the other ones are, I think I told you about, my wife had a patient who had a spiral fracture of the humerus, which nicked the radial nerve. So he lost tricep and he lost his wrist extensors. That happens occasionally because if you get a mid-shaft fracture, that's where the radius goes really close to the humerus. That would be one. Ulnar nerve is going to mostly always occur at the groove here, and that's usually blunt trauma here, or if we've got our baseball pitchers or what have you that have inflammation on the inside, whether it's a torn UCL or just some flexor tendonitis. If they get swelling here, a lot of times they'll get this last two fingers feel numb and tingly and loss of strength. Those are usually transient, but they can be more permanent if the condition is more chronic. What's our nerve glide for all those? Do you remember? Ulnar nerve? Yep. Right there. Median. Radial. Do you remember radial? Classification of nerve injuries: if you've got a neuropraxia, segmental demyelinarization, you know, we talked about the copper wire. Here's your nerve. Here's the myelin that surrounds it. That's the insulation that allows the things to go. So if you get compression here, it's going to die off both ways from here. You'll get latency as a result of that. Muscle usually doesn't atrophy unless it's going to be something that's permanent, but you get a lot of sensory symptoms there. Recovery is usually complete as long as you can get pressure off of this. So what is it? You know, again, the Saturday night palsy. Drunks lay with their arm underneath their pillow, fall asleep, their whole arm's numb for a couple days. I think I told you all about my tennis player who laid on the foam rolls. I was treating her back. She laid on the foam rolls for like a half hour. So she stretched out both brachial plexus to the point she had numbness and tingling for like 3 days, couldn't hold the tennis rackets, freaking out. She goes, "Oh, my back feels great, but I can't hold the racket because I laid here for that long." I'm like, who told you to lay there for that long? It just felt good, you know. You have to tell patients, you gotta give them some parameters. Oh, she was a piece of work. Axonotomesis. So if you lose the axonal continuity, but the connective tissue is intact, Wallerian degeneration, okay? Goes from distal to the lesion. This is big trouble here. You're gonna get everything lost. Fiber atrophy this is usually a stretch or a shear injury to the nerve. More times this is more serious and surgical intervention may be required. I've had a couple people with thoracic outlet problems, first rib that pushes on the nerve to the point that would get something like this, and they have to get the nerve released. So they'll take the rib out or whatever and take care of that to get some feeding back into this nerve, get blood flow back to the nerve, because the blood flow is getting cut off. We can't have that. We know that's not going to work for long. What do we try to do in PT? Pain relief? It's tough. Maintain range of motion, because again, they're probably not able to move whatever's affecting it distally. We may have to show them how to do that. How are we going to reduce muscular atrophy?
Use it.
They can't move it though. Not tens. Yep, your neuromuscular re-ed. You gotta keep that muscle intact. Patient education, telling them that, hey, nerve is live tissue. A lot of people don't really understand that it needs blood flow. Assisted devices, you may put them in a splint to keep pressure. If you can get pressure off of the nerve, sometimes you will splint things, which makes it a little stiffer, but you've got to get that pressure off of that nerve. And then the surgical treatment, reducing scar tissue. A lot of times when they free up a nerve, the neurosurgeon told me, he says, I just go in and I just take a probe and just move the nerve. So effectively doing a nerve glide, but he's doing it manually, okay? Just to get it moving again. Yes, sir?
Can you give me an example of how you do like neuro re-education for that, like with at the atrophy?
More times than not, if it's something like, let's say ulnar nerve, because that's what I think I've seen it more than anywhere. If you've got compression here, whether it's a bone spur, swelling, what have you, they're gonna start losing, what's this? Hypothenar eminence. If you see that start wasting away, you can stimulate that with electrodes or a probe. We don't have the probe here. Have y'all seen that before though? It acts as an electrode. You take it and you push it right here, it will contract right there. And you can hold that for however long you want to produce that contraction, okay? And that's what you'd see, they curl up like that, yeah. Again, lots more OT than what we tend to do. This is a complete severance of the nerve fiber. This is no recovery without surgery, and it may not even recover at that point. If the nerve is severed, they'll try to put it back together, but not always successful. So if you've got somebody with a nerve injury, so this guy that I saw, he had, I don't know what caused his nerve injury. It wasn't a stab wound. He was a cellist, and he ended up losing pretty much his entire arm, so they had to go in and loosen up the nerve, release everything. Acute phase, I don't think we did any immobilization with him. We did a lot of movement. I did a lot of passive range to begin with to keep everything moving, especially his hand. I mean, this is a guy that's intricate. He traveled the world playing the cello in front of Carnegie Hall and all this kind of stuff. We did not have to do any bracing. He was a relatively young guy, so he healed pretty quickly. Signs of reinnervation, again, we did some stem with him. We passively ranged him, and we just kind of kept watching things to see if he was getting some more firing through the muscles. We saw some improvement in the musculature. He kept getting better and better. And eventually just kind of discharged himself at that point, because the doctor was like, you're gonna continue to get better. It's like I always tell people about nerves. If it starts to get better and nothing else happens, it should continue to get better. Okay, so if you get somebody with a nerve injury, if you can get the environment right, And the environment's gotta be good. They get blood flow, they're going to get better, okay? That's our job. And, you know, it's, the physiology behind nerve healing is just incredibly complex, way too much for me. Carpal tunnel is gonna be the most common one that you will see. We've talked about all these things here. Discomfort is usually worse at night. That's because they tend to get into the hyperflexion or hyperextension. That's why the splint is a really good idea. And again, super simple splint. You don't need to go out and buy one of these. It's got the thumb spica and all that kind of thing on it. Just something that's gonna keep their wrist in a neutral position. You can even tape it. You know, I've shown people how to just do a tape job so they just stay in neutral. Here's the wasting. So you see a thenar eminence wasting. This is what carpal tunnel surgery looks like. It's just a little incision there. And honestly, carpal tunnel surgery is about a coin flip whether it's gonna help you or not. I think that's got a lot to do with a lot of other things as well. If they are sedentary, obese, retain swelling, all that's working against them, okay? So if you've got a pregnant female, I'm picking on ladies, but it just seems to be what it is, and sedentary, it is going to be tough to get that right, okay? You gotta encourage, it's lifestyle change. Get up, move around. Do something to get rid of the swelling. You're gonna maybe put a little sleeve on their hand, something to keep the swelling out of there, okay? Dion's canal, ulnar nerve entrapment. Can't say I've seen a bunch of this. I've seen it a lot at the elbow. I haven't really seen it in the wrist, but we know that that's where that goes. You can get compression anywhere if you got enough swelling. Cubital tunnel. The symptoms are very similar to hitting your funny bone, except this compression's occurring right here in the groove. And again, a lot of times this is gonna be from spurring. The bone growth presses onto the nerve. Again, some people's, it's just like your bicipital groove we were talking about. Some people's, the groove isn't deep enough. So when they move, that nerve pops in and out. Pops in and out, that's called a subluxing ulnar nerve. So there's a couple things they can do with that. They'll try to do an injection to calm things down, but if it has to end up being a surgical thing, they will take the nerve and they will deepen the groove and transpose the nerve, a transposition. They'll actually move it to get it more stable. They can actually suture it down if they need to, but they try to avoid that, because obviously that's gonna restrict the movement of it. But I've seen several of those. I've played with at Auburn. How she came here, he was like the highest recruit we ever had. And he got this, and his arm, I will never forget it. You looked at the size of his arm on the side that was, ulnar nerve was involved. I mean, this was just skin and bones through here. He ended up having the surgery. They moved the nerve. He never got it all back. I mean, it just took forever to get his strength and his mobility back. Never was the same. Never was the same. Rheumatoid arthritis. Anybody do the 360 today? Did you see the question? Did you get it right? This is when you're going to see the distal extremities, deformities. More times than not, you'll see this ulnar drift, so the fingers will shade to the pinky side. Heberden's nodes, these are large nodes at the joints. Gosh, this is brutal. I mean, it really gets problematic. And you see both swan neck and a boutonniere deformity. We talked about those, right? You got one that looks like that. That's a boutonniere. And then the swan neck, because all of this destruction occurs at all these extensor hoods and so forth. And tendons will slip, the pulley system slips. It's a mess. It's a mess. This is really hard to treat. And rheumatoid is a systemic thing. You guys know this, as opposed to osteoarthritis, right? You've got to deal with rheumatoid from a systemic level. So they're gonna be on different medications. Back when I was in school, it was gold therapy. Anybody heard that before? They gave them low doses of gold that's supposed to reduce that inflammation. I don't even know if they do that anymore. I think there's all those other autoimmune drugs that they use more nowadays. OA, this is where you're gonna see more distal again. This is RA, the ulnar drift with the boutonniere, as opposed to the OA, which tends to just be more, just like more localized, less deformity. So what would be the difference here? Which one of these would respond well to heat? OA. OA. You don't want to heat this. Did you have a question, Steve?
Yeah, I notice you keep saying ulnar drift, but do you have radial drift or?
I don't think I see much radial drift. I don't know why that's the case either. Yeah, if you see somebody with RA like this is, I think I treated one person with RA that had 7 total replacements. Both hips, both knees, one elbow, a foot. I mean, it's just so destructive to joints, it's horrible. These are the kind of people that you will see, folks with RA will have a total hip or something, total knee early on in life. Early on in life. Wrist replacements, I've seen all those things. This one right here, that's probably somebody pretty young. They can replace the MCP joints even. Exercises. Okay, this is the kind of stuff that we can talk about. Tendon gliding. Think of this as flossing for our tendons. If you pull into flexion here, look right here. You see those flexor tendons, palmaris, all of those working. Keep the MCP straight, and you'll feel that pull right in through here. That effectively flosses the carpal tunnel area. If you've got somebody that's got a lot of swelling there, that's a good exercise for them. Tendon glide, okay? I give this all the time to people here. Now, you can make them do a full fist as well, but you'll get a better pull actually on the tendon if you can keep that MCP straight. And then, of course, just strengthening. You're working against resistance, whether it's gripping, hand grippers, putty, washcloth, Nerf ball, tennis ball, something that they can keep squeezing. Again, blood flow, we know that's good, right? So let's look at lab and see what we've got. Valgus extension overload.